Good afternoon, everyone. My name is Belinda, and I'll be chairing this afternoon's seminar. Before we begin, I would like to acknowledge that I am hosting this meeting from the lands of the Gadigal people of the Eora Nation, the traditional custodians of this land. I pay my respects to elders past, present, and emerging, and recognise and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I extend that respect to Aboriginal and Torres Strait Island peoples who are here today. So this afternoon's seminar will be an overview of the Stepping On program. We have a few presenters with us today. Ms Megan Swann is an occupational therapist and a co-author of the Stepping On program. Megan has been facilitating Stepping On programs and training facilitators to embed the program in their work practice for over 24 years. Alongside Megan from the University of Sydney, we have Emeritus Professor Lindy Clemson, who will be talking about the evaluation report and work she did in the US, Dr. Serne Paul, who will be sharing with us the Stepping On evaluation report she worked on for the Australian context, and Professor Anne Tiedemann, who will talk about the falls prevention behaviour following participation. Before I hand over to Megan, just a friendly reminder to please place yourselves on mute while the speakers are presenting. Thanks, everybody, and over to you, Megan.
Firstly, thank you very much for the opportunity to speak today. I'm very excited to be talking about my journey, that is translating research into practice, a clinician's view. Firstly, for those of you who have not heard of the program, it's a 7-week community-based, evidence-based program that runs for 2 hours each week for 7 weeks, but it has an extra booster session. It's a closed group with older people of roughly about 12 people. They meet at the same time and place each week, and the program is based on current falls prevention knowledge and work and has a very strong behavioural cognitive approach. It is quite unique as the delivery of the program sets it aside. So it's not the topics alone, but it's also how it's delivered. Where are we today? Stepping On was delivered, researched initially in Sydney, Australia, and is now represented in most states of Northern America through Wisconsin Institute of Healthy Aging. It has been supported by New South Wales Health since 2008. There are other states in Australia running groups, but not on the statewide rollout as in New South Wales. Stepping On is also being run in Aboriginal Torres Strait Island groups, psychiatric outpatient settings, cancer groups, carer groups, stroke participants, and as we know it, it's also being run in Sweden, Hong Kong, and Singapore. Handout for the resources for 17 other languages. They're also available on the Sydney University Press website. I thought visually I'll show you. This is we've just published the US Spanish-speaking first edition, Pasando Fileta, I hope that's pronounced properly, and for the US Spanish speakers, which is very exciting. That came out this year. Then on the left, we have the Australian manual, which is the first manual that was written, and it's on its 3rd edition, and it came out in 2019. On your right is the Northern American edition, 4th edition, and training through the Wisconsin Institute of Healthy Aging, and that came out in 2023. Staying Power is a book, a companion book for older people who have not the ability to attend Stepping On, written for the consumer, and it's all these books are available from Sydney University Press. Now I thought I'd start with a story. We all love stories in Stepping On. Storytelling is very powerful as a facilitation tool. It is more effective than facts or explanations alone in influencing thinking and behaviour. Our level of attention is heightened when the story has meaning to us. It resonates so much more, and that's why I think that's the reason why Stepping On works across nearly all cultures, because storytelling is so important. I'm going to tell you the story. A car was travelling at 90 kilometres an hour on a busy road. A woman in her 30s was seriously hit as a pedestrian on Parramatta Road, Burwood, New South Wales. She lay in hospital for 6 weeks and had a long period of recuperation and rehabilitation. Although younger than most older adults, what followed was her insight into the journey older people have had after a fall, the physical and emotional journey. The physical pain, spasm, pressure areas and all were all one thing, but the psychological effects were far greater. First, the hospital. She found that she became a number and people related to her differently. Some staff tended to patronise. In fact, now lying vertically, they assumed her intelligence had vanished. They talked above and over her as if she wasn't even in the room. She was just another motor vehicle accident. But it was dealing with the psychological moments that affected her the most, a feeling that her body had let her down. Low confidence, a feeling she may fall over again, vulnerability, loss of control. She tended to doubt herself constantly. And she also didn't, she was younger and she didn't have health professions and families saying, what do you expect? You're getting older, as an older adult would. After returning home, she had one incident stand out in her mind. She was at a big sale in a large department store. This was her first shopping expedition. She had a walking stick and a bag in the other hand. She approached the escalators thinking, good leg first. She got on, so proud of herself. She had got on. Halfway down this steep descent, she felt a sense of doom. Many people had alighted at the base of the escalator, talking with all their bags, and they'd stopped. Could she get around them? Would she fall into them? It was just, she started to panic. It was one of the scariest moments of her life. Her legs were not strong, her balance was not good, and she had these self-doubting thoughts which are coming in, which is making her freak out. She had lost confidence in her body, vulnerable. She started to limit her shopping trips into unfamiliar areas with clients, with no crowds. It was easier and safer to stay at home, she thought. That person was me. That's me in 1994. I got hit by a car. Translating that to someone who may have other issues, vision, impairment, loss of hearing, arthritis, you can understand how fear takes over. Fear makes you hesitant and unsteady. Every step becomes a challenge. Therefore, one avoids situations which leads to deconditioning, isolation, anxiety. I had lived experience, although younger in age. So, how did we get stepping on to where it is? Well, this is my journey, and this is I will go through it. There's firstly the method. I was working at Redfern Community Health 25 years ago, and I formed a partnership with Professor Lindy Clemson in 1999, which is a pilot group, which was promising. We received funding from a Lindy received for a large randomized control trial. And I was involved in running the groups for 1 year. I was the main facilitator and mentored staff. That's me on the left. However, we didn't know it worked till after the data was completed and written up and published in 2004. I intuitively knew it worked, and I luckily received a grant for 2 years through the Nursing and Allied Health Resource Unit at Camperdown to run an evaluation, small, but evaluating falls efficacy following a community-based falls prevention program for older people. The results were significant, but the sample size was small. But it meant I kept the groups going. The guest speakers we kept the capital, the enthusiasm, the momentum, and we have built up through the randomized controlled trial and kept the program alive. Balmain Leagues Club and Leichhardt Council were very supportive. I wanted to embed the program into the Glebe Community Health. After the randomized controlled trial was published, the effectiveness of a community-based falls prevention program for reducing the incidence of falls in the elderly was published in 2004. So it worked. So how do we get this into practice? There was no roadmaps. And I'm very aware that it can take up to 10 years at least for research to get into practice, and sometimes it never does. It sits on a bookshelf somewhere. It comes too hard to change clinical practice with busy caseloads even though results were very impressive, 31% after 14 months. So where to from now? What do I do? Well, it didn't seem to be any roadmaps out there, but the quickest way to succeed is to start and to figure it out as you go. So this is what we did. So Lindy and I formed a partnership, and me as a clinician, I started working with my networks. I would say that persistence and passion paid off. I moved to Prince of Wales Hospital in 2005, where I was very well supported by the occupational therapy manager and physiotherapy manager, and supported the program as an outpatient group. Professor Jackie Close, the geriatrician at Prince of Wales Hospital, had just started working there. She'd come from the UK. She started the Falls, Balance and Injury Research Centre at Neura, and she put stepping on as a falls pathway, which really embedded it into the program. Now it's still embedded into the clinical pathway there since 2005. I worked at Prince of Wales for 15 years. I also worked at St Vincent's Hospital, Darlinghurst, in the community centre. I worked in health promotion and ran over 8 groups a year over 4 years. They were very supportive and encouraging, and it was always about the patient, and it was what was best for the patient. So it was a very, very supportive environment for wellness, active aging programs. Partnerships. Well, there's quite a few. I met Professor Lindy Clemson in 1909, and we instantly collaborated. She's the academic, me as the clinician on the research paper. This partnership is still very strong. As you will see, I'm in her lounge room. We wrote the Australian manual in our free time in 2000, not knowing whether the program would work, but it did. It certainly did. I've also had a partnership with, we've had a partnership for 15 years with Sydney University Press, which has helped a lot with the manuals, and it's helped a lot with the copyright issues and the fidelity of the program. Then the Ministry of Health in 2008 rolled out the program across the state. We're still getting support from them now. I've trained for primary healthcare in Perth, Tasmania and Queensland. I want to thank the support of Royal Ride Rehab College and Royal Ride Rehab New South Wales for 4 years with their training admin staff. I've conducted over 400 programs and still do. I've run over 200 training programs face-to-face and via Zoom during COVID only. I now run training programs as a private consultant. The training and the mentoring continues. Stepping On keeps evolving. I want to thank the countless allied health clinicians that have helped me on my journey. I want to thank the Stepping On coordinators that started in 2008, and a special thank you to Nadia Williams and her team at Royal Ride Rehab that have been very, very supportive and helped with the program rollout. Evidence to practice in the community is very difficult. Pressure on waiting lists, easy to resort to default, a medical model. There is no overt opposition to Stepping On, but clinicians tend to follow established practice. Translating research to practice is complex, slow, and long-term. Maintaining program fidelity and tension of what's easy to be delivered and what's best practice is constant being evaluated, and it's constant being pushed. And I'm very aware of that it's people will default to the easiest option when you want the program, the fidelity of the program to be right for it to work. A champion is needed who is committed. What makes Stepping On work is that it's this connection, engaging with people. There's many other factors, but from my point of view, the program is now being driven by the consumers, which actually, there's long waiting lists and everyone adores the program. For more information, I would like you to visit, and you can always contact me. I'm very available. I'll answer very quickly, www.steppingon.com. And this is a picture of the girls or people in Sweden where it's being run, and it's, as you can see, they're very happy. So is there any questions at all? No?
Linda, did you want questions now or at the end?
If anybody's got any, they can jump in quickly now. Otherwise, if anybody thinks of questions at the end, we can do that too. So if nobody has any immediate question. Oh, Kathy?
Sorry, can't find the hand raised thing. Not a question, but just want to say thank you so much. What an amazing overview of a massive body of work and and implementation. And I think actually Andrew might have a question.
I'll just ask it. I put it in the chat. Yeah, just interested to know what is the reach of the program, because I was in the ministry many years ago around that 2008 period with Brendan Goodger when a decision was made to fund. So yeah, what is the reach of the program currently in New South Wales, but also in other parts of the country?
Well, from what I know, Lindy might be able to mention, but what I know is that it's under the umbrella of active and ageing, but we've been running Stepping On now since 2008 in New South Wales Health. So I know that NGOs are picking up, and sometimes partnership with New South Wales Health now. But what you mean, how many per year, like programs per year? I think you'd have to ask the Ministry of Health that question, because I'm a private consultant, but I do know that it's been run, and in some area, and some LHDs are much more prolific than others, for sure. Some have got long thousands of people on the waiting list, and others who haven't picked it up as much haven't got as many. But when they're running it well and properly, it's just phenomenal. So, yeah, that's all I can say.
Yeah.
Thank you.
And just a quick follow-on question. So it's uses a train-the-trainer model, and your role now currently as a consultant is going around and helping people to establish programs and run them efficiently.
No, my role at the moment is they come to me and I do face-to-face training. I also run. I'm still running programs. I run programs for LHDs. So, but if anyone wants to come and watch what I do, that's fine. But hopefully that the person, when I do the training with someone, that they can go back and watch a program. And there's enough programs out there for people to watch a good program. So it's an introductory day. It's not like in America. It's a 3-day training course, and it's accredited and it's licensed. You have to pay money and you get checked for fidelity every year. So we don't have that in Australia. It wouldn't work, that model in Australia. No one would pay. So we have an introductory course, and then I do and I suggest that they go and watch a program and be mentored and be a co-facilitator before they go out and run it themselves.
Yeah, well, look, I commend you on the work. It is a program with really wide reach, but yeah, just interested to know some of the factors that might contribute to its success. And obviously, as you say, the US has a commercialized model, but in Australia it isn't. So yeah, you are training people to spread the program and continue it. So it's very interesting.
Yeah. I mean, I would say the reason that it's working, it's from the ground up. The people love it. The consumers love it. So it's working like word of mouth out there, and it's working. Obviously, it's filling a need, and people always come back saying, "You've changed my life. I've got my bounce back in my step. I'm going out now. My confidence has improved. My strength and balance." It's a multifactorial program, and it's quite empowering. That's the reason why I'm still running it. I've still got passion for it, because I can see how it changes people's lives. So,
Thank you.
Okay.
Thank you. We're just swapping over here. Okay, thank you. So I'm going to talk about the journey in America. And back in 2000, I think the year after we published our paper, I had this phone call from Professor Jane Mahoney from the Wisconsin Institute, the University of Wisconsin in Madison. in the US. Jane has been a real expert on dissemination and implementation of evidence-based prevention programs in community settings. And she'd also already published a falls trial and understood, which wasn't effective for everybody, but it showed a lot of promise. And she understood the importance of prevention and was very interested in stepping on. Jane created the Wisconsin Institute for Healthy Aging, which is a non-profit organisation which disseminates high-level evidence-based health promotion programs. Through their training activities and resources, and now including Stepping On, they've delivered it to Wisconsin's 72 counties, as well as nationally now. They have the institute in Australia, but in Australia, we have Megan, who's doing the same thing, as she's just explained. Jane has given a huge investment in implementation research of Stepping On and in the local and national dissemination in the US. But as Megan says, this does take time. The first study was a pre-post evaluation, a fairly small one, but Jane rang me and I'll never forget that day. She said, Lindy, it didn't work. We couldn't show any reduction in falls. And I thought, okay, well, that's it. We can do this amazing program, but how can we translate it into practice? Undaunted as Jane was, it just raised questions really for us both. So when new programs are introduced, it is not known if in translation they keep the fidelity of the original intervention. And research is a long-term dissemination of evidence-based programs is really lacking. And so the work I'm going to share with you today that Jane did is really quite unique. So she started out with a root cause analysis to identify lapses in fidelity and what solutions were needed. And 3 poor Stepping On coordinators had their programs investigated in great depth. And they looked at some of the lapses in fidelity, things like they had few stories, they weren't using the preventive framework prompts that we developed, there was no time for questions, all the things that Megan can do. They were not doing. There were things about the group size and also the participants were quite frail in some cases. So with that knowledge, they went on and we actually, with Jane leading, undertook a Delphi consensus of the key to explore what the key elements were in our conceptual basis of the Stepping On program. And Jane had the broader aim to finalise a training package that would be ready for dissemination. And as always, the implementation research is grounded in the theoretical frameworks, as in this slide. So in our Delphi review, we had 19 international experts, and their consensus was that they supported the conceptual underpinning of Stepping On. They supported the prime components of adult learning theory was essential, principles of self-efficacy were rated as highly important, and the decision-making prompts were rated as important. That leaders required skills in these concepts and in group work and in knowledge of falls prevention evidence. The top 5 were those on the screen about being meaningful, relevant, trust and reflection being important, and a sense of ownership. As you can see, they're the things that Megan holds as the reasons why the program's successful today. So finally, we get to this stage where we conducted Jane led a pragmatic sequential pre-post design, which actually spanned about a 6-year period, a bit like a step wedge design, really. She published the results in 2020. Megan and I were hanging out for many years for these results to be published. Kept saying, Jane, when are you going to publish them? Finally, they came out with this really excellent implementation evaluation paper. So these were our results. The falls outcome was very positive. After 6 months after the Stepping On program, compared to the baseline period, there was a significant 38 reduction in falls. And in the second 6 months at 1 year, at the 12-month, there was a significant 28% reduction compared to baseline. Also, the falls behavioural scale showed significant improvements in both follow-up periods. And these were consistent results with our Australian RCT, which showed 30% reduction. Improvement in effectiveness was concurrent with the better program delivery that Jane had undertaken and developed. So in summary, stepping on can be implemented with similar results as achieved under a research context when attention is given to key elements in training and in program implementation. Training, master training and fidelity testing continues, as Megan says, in North America from the Wisconsin Institute, and it is crucial to successful outcomes and has enabled broad dissemination at a state and national level. There's been lots more studies that Jane has conducted and led in the US. And this one is a quality improvement intervention for rural country areas to sort of scale up in those areas. So the Institute taught key organisational change principles to process improvement coaches that were in the organisations and were taught using a series of change cycles, which kind of identified problems and solutions around adoption and delivery. They increased the number of programs in those rural areas by 1.5-fold for the 16 participating counties in a waitlist cluster randomised trial. And they also showed they had fewer falls, fewer risk behaviours, and also fewer medical record verified emergency department visits. We'll hear from Serne, though, about a huge study that she's been leading here, had led in Australia around things like that. And this is just the story of America from the time we first met Jane. We've known her all these years and communicated with her amazing OTs that lead the program over there. As you can see, it takes a long time and a lot of investment and passion and commitment to run long-term implementation and achieve national dissemination, as Jane has and her team in the States. And they now have, they've done the train the trainer so that they have trainers in different states, and they are now disseminated actually nearly in
you have to do it or
this one, as I said, Jane's connects with all these amazing people. And this is just one example of the papers that have also come out looking at running Stepping On with other groups of people. Barbara Fisher was a psychologist who developed, she called it Stepping Out. And in this article, she does talk very closely about what she did and how it compared to the original Stepping On program. So she made some additions, but it really lended itself well for this group with particular adaptations. So that was with people with mild cognitive impairment. We've had other people look at Tanya Wilds in St. Louis took Stepping On and did it with a group of people with cancer and introduced more emphasis on looking at other aspects of cancer, but they're thinking about where people's thinking changes a bit, and also they have a lot of trouble with, I'm trying to think of the word. I've lost my words there. They have, yeah, I'll think of it later. But she added a few extra sessions to it, and it worked really well. She did an amazing job. And I just wanted to finish with, we're very excited, as Megan has said. And as you can see, each of our books have a different colour. And this is the Spanish book. So I hope you appreciate the Spanish colours that Megan and Maria chose. So Maria Pinson is this amazing geriatrician who works in Jane's Department of Medicine at Wisconsin Uni. And so she wanted to bring Stepping On to the Hispanic groups. And so she created Pasande Fuerte. I can't pronounce it either. So sorry to our Spanish speaking people, but it means stepping strong. And based on the results of a pilot, she made a few changes to facilitate adoption and implementation by different community groups. She added an additional session to allow for additional interaction. She looked at expanding the types of leaders to educators and community health workers who worked in these areas. And so she added a chapter on just cultural differences and things like that. And she talked about how, and Jane was amazed at how she said that it needed to have a lot of fun in these programs, but that wasn't really news to us, was it, Megan? So they're fun programs. So we're very excited about the work that she did and all the interviews with participants and leaders of the program she ran in the pilot. So that's our latest Stepping On program. So I think I'll end it there and hand over to Anne. Thank you.
You want me to go ahead, Belinda, or?
Sorry. Yes, did anybody have any questions for Lindy at this stage? All right, perhaps I'll pass over to you, Anne, and we can come back to any questions at the end.
Okay. Now, is that sharing correctly?
Yeah, that looks good, Anne.
Good, that's excellent. Okay, so thanks very much to the organisers for inviting me to speak today. So, it's so amazing to hear about the implementation of the Stepping On program, and particularly the translation to Spanish. That's amazing. So what I'm going to be talking about is a research study that we conducted quite a few years ago now. But the aim of this study was to really look at implementation of the program in the real world, and it was a pre-post study, and to really document the ongoing participation in evidence-based fall prevention interventions after people took part in the Stepping On program. Just make sure I can progress my, okay, good. So the aims, so we were, as I just said, we aim to document ongoing participation in the interventions and behaviours that Stepping On the program teaches participants. And we also were interested in the barriers and enablers to ongoing participation in these interventions and behaviours. And so this research was published a number of years ago, back in 2021, and you can see the reference there. So what did we do? So we recruited participants who were attending the Stepping On program from 2015 and 2016. Basically, the way we recruited was the information about our study was provided to participants at the first session of Stepping On by the program leaders, and then all the follow-up was conducted by our research team. And so we took a number of measures at baseline. You can see them listed on the right here. So we asked about current fall prevention behaviours. We used the Falls Behavioural Scale, which is a list of 30 statements that describe things that we do in our everyday life that are relevant to risk of falling. For example, one question asks, when I stand up, I pause to get my balance, and people need to respond as to how often they do that behaviour. We also used the incidental and planned exercise questionnaire to document how active people currently were. And then we asked a series of questions about barriers to uptake of fall prevention behaviours. So we undertook this survey at baseline, and then we followed people up at 6 months post completion of the Stepping On program. And so what were our results? So we managed to recruit 458 participants, most were female, so 75% were female, mean age 77. Around 60% had fallen in the past year, and around 67% attended the Stepping On program in a metropolitan LHD. So we did try to recruit from across New South Wales. The negative part, or the weakness of this study, is that our follow-up was quite low. So we only managed to follow up 64% of people at 6 months. So we had quite a lot of people who we were unable to contact them at the 6 month point. And so you do need to bear that in mind when we're talking about the results of this study. So overall, we found that a high number of people, so out of the ones that responded at 6 months, we found a high proportion completed the full program, so 86%. 98% of people said that it did increase their awareness about falls and fall prevention, and 65% felt that they had increased their independence as a result of the program. And amazingly, 98% would recommend the program. So a really huge positive vote of confidence in the benefits of the program to these people. In terms of the strategies, so we looked at what strategies people were using at baseline and compared to the follow-up, how did that change? And you can see the main changes that we identified were that there was a huge increase in the proportion of people who were undertaking regular strength and balance exercises at that 6-month time point. We also found that there was a significant increase in the number of people that were undertaking safe walking strategies still at that 6-month time point. So that was really encouraging to see, because we know that the evidence shows how important regular strength and balance exercise is for preventing falls. And you can see, interestingly, that at baseline, people were undertaking a number of other interventions and behaviours that were protective in terms of risk of falling. So, for example, 43% had already had cataract surgery at baseline. And you can see that that dropped off at follow-up because people had already had the surgery. So at follow-up, they can't have it again. So that's why there's a sort of a bit of a funny result there in terms of a decrease in some of these behaviours and interventions. In terms of our other measures, so we found that overall there was an improvement in the falls behavioural scale. So the mean score out of 4 went from 2.9 to 3.1. It's quite small, but it was a significant improvement. And this just shows that people were undertaking more of those protective behaviours as a result of taking part in the program. We also detected an increase in structured exercise on the IPEC. And so that was also encouraging to see that people were had increased their average number of minutes per week of doing structured exercise, or hours per week, that is. Went from 2 to 4 hours a week. In terms of the barriers, so the main responses that we found for barriers to undertaking exercise in the participants, you can see them listed here. So people talked about having poor health, not enough time, transportation difficulties, or responsibilities for caring for other people. And the factors that would motivate people to undertake more exercise were linked to things like improving their health, having a local program or transport to help them to access those programs, and having more available time. So they're quite common reasons that people give in research in terms of barriers and motivators. And so overall, just to summarise, we found there was a high level of acceptability and satisfaction with the Stepping On program. Importantly, we found significant impact on some really important fall prevention behaviours, and these were lasting still at 6 months. So this is not just immediately post completion of the program, this is 6 months post completion of the program. So we saw that lasting effect of taking part. And so we did conclude that it does have an impact when delivered in the real world. So I'd just like to acknowledge the study funding, the collaborators on this research, and the staff that undertook the program with me, and my lovely parents there who also took part in the Stepping On program and found it to be really beneficial. So I'll stop sharing now.
Thanks for that, Anne. Did anybody have any questions for Anne?
And now my controls are, oh, there we go. There we go.
Okay, we might hand over to Serne in that case. And if anybody has any questions at the end, we can come back to it.
Okay, I'm hoping everyone can see the right screen, which is the presentation mode. Okay. So we ended up having a really big team of collaborators across the 3 studies that looked at the impact of stepping on in New South Wales. I'll skip over this background because we've heard quite a bit about the Stepping On program already. I guess the main things to point out were that even though the program started being rolled out in New South Wales in 2008, it achieved statewide coverage only in 2012. So it was sort of rolled out across various LHDs to achieve. It started out LHD by LHD. So the aim of these studies were to evaluate the impact of the scaled-up delivery of Stepping On in New South Wales. And given we didn't have access to the individual Stepping On participants or groups, we used full related health service use as a proxy. And so that meant when people fell and ended up needing to use healthcare services like admission to hospital or ambulance. So the specific research questions were whether there was a detectable impact of the program on full related health service use, and then whether there were differences in the patterns of use among those participants that we could track before versus after the program compared to before. And then we also looked at trying to match Stepping On participants with controls who also lived in the community, and as much as we could match them based on similar demographics. So the first study was the population level one, and then study 2, we had 2 studies, one just looking at the participants and then the second one comparing to controls. So for the population level analysis, we used a step wedge analysis looking at these 3 outcomes: fall and fall injury related hospital admissions from the admitted patients data set and ambulance use. Important to note, these 2 data sets were analysed and were maintained separately. We didn't have the ability to link them back when we conducted this study. So New South Wales Health gave us information about their programs in terms of location and dates of delivery, and these were mapped to statistical local areas according to ABS data, and then superimposed onto the, and those layers of geography were then used as the units of analysis in multi-level Poisson models. For the second study, it was a little bit more straightforward. We could actually link the participants this time, so we could actually track their journey through hospital, ED, and ambulance use. And to do the matching, where we had enough identifiers from participants, we could match them to the 45 and up study participants to get a sense of their fall-related health service use. I'm sorry, I'm realizing with my organization, I probably should have kept study 1 together. So at the population level, in 2008, it was piloted in 2 LHDs, and then the statewide rollout officially began in mid-2009 and achieved statewide coverage by 2012. So we had just over a 5.5-year analysis period. And during that time, New South Wales Health, through their NGOs and LHDs, delivered over 1,000 groups to about 10,000 participants, which is a lot of volume, but compared to the eligible population of people aged over 65, even though we don't know at the population level how many people would be at risk of falls, it actually is less than 1% of the New South Wales population in that age bracket. What was also interesting was that across all the LHDs, there were areas of geography where about 10, up to 16% of the older population age over 65 did not live in an area where Stepping On was delivered. And what we know over time is that fall-related health service use is continuing to increase, and unfortunately that isn't really abating. So it's in this context of ongoing increase that we're presenting these results. So what we know is that when we analyze the periods following stepping on delivery compared to areas without stepping on, the rate of fall-related hospitalizations generally were unchanged or were on the slight rise. Because the estimates cross zero, they're essentially not significant changes. So at the population level, stepping on did not have an impact on or detectable impact on fall-related hospitalization. However, it looked like there was a trend towards reducing fall-related ambulance use. And it was actually a statistically significant finding in reducing fall-related ambulance use among people aged 75 to 84 years at this population level. So given it was quite hard to detect an impact at the wide population level using fairly de-identified data, the next two studies were trying to look at what was going on with the actual participants themselves and was there a detectable impact. So from the data that New South Wales Health provided us, once we sort of excluded dodgy linkage and so forth, we had about 9,000 participants. We examined their first program use because about 200 to 300 of them in a sort of 5 to 6 year period actually attended multiple stepping on groups between 1 to 3 years apart. In terms of demographics, we can see a lot of them were over 75 years and not surprisingly were females. I think this also spoke to Megan's point. 4 LHDs out of the 15 delivered over 10% of the stepping on groups across all of New South Wales. So 2 are metropolitan and 2 are rural. Yeah. And this was the trend that we saw. So the lines are the various types of health service use. But what we see is that with our stepping on participants, the red line indicates when they enrolled in a program. What was really interesting is that in about the 6 months before program, they had a massive spike in fall-related health service use across just about all types of health service use. And then following the program for about 3 to 6 months, their health service use drops off, more or less stabilizes for about the first 12 months and then slowly starts to increase again over the next 2 years later, so for a total of 3-year follow-up. And when we looked at study 3 of matching the participants to controls, and what we could match participants on were these 3 characteristics of sex, age group, and fall history, we end up with a sample that is about 15, probably more like 20% of the overall stepping on participants. What we do actually find that's quite interesting is that trend from the larger cohort of participants holds true here. The solid lines are the stepping on participants, and they really do have that spike in fall-related health service use before program entry, whereas the controls do not. But what is interesting to note is that controls do show that trend that as they age, their fall-related health service use is increasing. And what we were able to demonstrate is that the stepping on program appeared to attenuate that spike in health service use and actually basically help the participants achieve that baseline of the controls where they end up being very similar in this follow-up period. And this is what this showed in this comparison, that the stepping on group is overall worse than the controls. who weren't identified to take part in stepping on. But when you look at the group versus program period interaction, these significant interactions, particularly for emergency department use and paramedic use, shows that the program does stop that rise and that huge spike in use and gets them to be more similar to the controls. So if we look overall across the 3 studies, what we can see is that participation in stepping on in New South Wales did reduce fall-related health services at the participant level across hospitalizations, emergency department visits, and ambulance use. And we would say the effects tend to be stronger in ambulance and ED. And for whatever reason, there seemed to be that pre-program spike in fall-related health services before participants enrolled in the program. So it could be that they are really reaching this tipping point, and then it's landing up in hospital or using services that is then prompting either the participant or their various healthcare providers to refer them onto the program. We do tend to see in subgroup analyses that the younger participants, so those aged 75 or under, get the biggest benefit in terms of reducing fall-related health service use. And in some of the findings, it showed that the males had a slightly different impact. I think if I went back here in this study, where we compared to controls, these findings held true for women but started to dissipate among the men, which really suggested that there might be a need for healthcare professionals to engage with the men in a different way to the females to help them to really adhere and take up fall prevention interventions. So that is my very quick... What I wanted to also say is that stepping on is overall very cheap compared to hospital stays, emergency department visits, or even ambulance use. And so the results do indicate it is quite a cost-effective falls prevention program, given it mitigates that rise in fall-related health service use among older adults. And I think study 1 really showed that insufficient reach doesn't translate to population level outcomes. And so there is a need to implement various fall prevention strategies and really improve the widespread implementation, as well as explore ways to maximize the effects in different subgroups of older adults. And these are the 3 publications of those results. Thanks.
Thanks for sharing that, Serne. We've got a few minutes left now if anybody's got any questions for Serne or any of our other presenters. I might start with a question. Andrew, did you want to go first? Just seen your hand, sorry.
No, you please go for it, and I'll go after you.
Just a question for Lindy. I noticed on the US timeline, the 20 to 21, that there was a stepping on virtual. I'm just curious, was that related at all to delivery within the rural setting, or perhaps COVID? If you could speak to that a little bit more, and whether there's been evaluation done about effectiveness in that setting.
No, it was just a reaction to COVID-19.
Okay.
And so no programs were running. So we were asked if they could do it virtually. So they developed a virtual program, and Megan and I worked really hard during that COVID-19 period, and some people delivered it remotely. Not as good, very challenging to run a group program that way. But no, it wasn't just rural areas. It was just in response to COVID-19.
Thanks, Lindy. Andrew?
Lindy, I've just got a question. Has anyone written up the pathway of the scale up of stepping on in Australia? I noticed that the US study did sort of do a bit of a typology over time, saying these are the new learnings over time. The program had reached so many people. Have you systematically written it up in any way?
No, but I wouldn't have that information, Andrew. I mean, we had a lot of funding. Jane had a lot of funding to do that. It was kind of like a step wedge, and not really, but it was kind of like that. So it was, looking at that data over a long period of time takes quite a bit of money to do that. So we did a lot of work in writing up that evaluation. So, I mean, we've had a number of studies done in Australia as well, but most of the studies have been done in the US. But I would say that our training here is the same quality as the US. I've been to both. I'm fully aware of what they do there. We've had, Megan has had a lot of interaction with the OTs there. We use the same manual, the same principles. When they first started doing the training, they were very concrete, weren't they, Megan? And we were probably a little bit not enough. And we both kind of learned how to do that training better over time. But Megan, I think, has always, had an understanding of the key elements. In the new manual, the key elements are very much part of that. And we've done a logic kind of concept map of how to run it. So, I mean, our understanding is based on running things here and over there. But no, we haven't done the same evaluation as here. But if you'd like to pay us, Andrew, we'd be happy to do so. Well, no, I wouldn't. I'm retired, come to think of it. Someone else would be very happy to do that. But I guess that the reach is interesting too. Actually, sorry, is that all right, Andrew? I've got a question for Serne.
No, that's okay. Yeah, no, I think it's because there are so few examples where the story of scale up has been written up. So obviously myself and Karen Lee and others have done that with some initiatives, but really this is a fantastic example, and to get a better understanding of what the implications are for implementation at scale. And it's really almost performing, it's not the right terminology, but almost a meta-analysis of all of what's happened over time and building up a story about how implementation occurred, what characteristics contributed to success or not. And that's rarely done because it sort of cuts across multiple studies, and no one really would fund you to do it, if that makes any sense, unless you were a funder or an owner of that particular initiative and you wanted to find out more about it. But it does, in my mind, it does sound like something that would really benefit from that story being told in a systematic way and gathering of evidence about how what the implications are for practice and research. But anyway, but if we get money, it'd be good to do.
But we also know how important those champions are, in any of these kinds of programs who support it and have that passion. So, and different areas. And yeah, I guess my next question too, or my question, Serne, and I know I was involved in all that research, and you said that Stepping On had a 1% reach, and that was 10,000 out of the population. But it's interesting, you were then saying that most of the participants in that last study came from the 4 areas that were very active. And I think Megan's very aware probably which areas they are that are very active. So I guess we don't kind of know what the percentage of those at-risk people would be getting that in those areas.
And that was one of the big limitations with the population level, because it was all de-identified ABS data. We knew we could identify based on geography of where Stepping On was rolled out and the density of Stepping On rollout in those areas. And we knew we could identify people aged over 65. That was it in terms of then making some of the assumptions around what was the level of reach and what proportion of people aged 65 and over would be at risk of falls. But given Stepping On is trying to get in early to people, in some ways you could argue a lot of people, if they're already starting to experience any mobility hesitancy or deficits, can self-enroll into the program. It was just they didn't yeah, we calculated reach also based on the number of groups that New South Wales Health told us, and the estimated size was between 8 to 12. So we just took an average and assumed that each group would have at least 12 participants. It could have been less. And that allowed us to estimate the number, but it was a very small proportion of older adults in New South Wales.
Thank you.
I'm just aware that we've hit 2 o'clock, so we might have to wrap it up there for today. So thanks again very much to Megan, Lindy, Anne and Serne for sharing your work, and have a good afternoon, everybody.
Thank you.
Thank you.
Thanks, everyone. Bye-bye.
Bye.